We're going to have a lecture on the national healthcare system, right? The basics of national healthcare systems, how they are structured, etc. Okay, I want to acknowledge the person who assisted with preparation of the slides for this lecture, Dr. Helen Eklund from Monash University in Australia. Okay, let's start with an interesting slide talking about unhappy doctors. Okay. Unhappy doctors, is there any connection to the national healthcare system? Right? According to a survey done in 2014, 52% of practicing American doctors, that means those who are actually seeing patients now, still active, right, say they would choose another profession if they had a chance. Right? Why is this so? 52%, one out of every two practicing doctors in America. Right? Can you think of some reasons why? Okay, so to keep you in suspense, I'll show you the slide at the end of this lecture. The last slide in this lecture will give some reasons. Right? Is there any connection about the unhappiness of American doctors to the nature of the American healthcare system? Right? A question to think about. Okay, lecture objectives. What do we mean when we say the national healthcare system? What are the main components of a national healthcare system? What are the objectives of having an integrated national healthcare system? We will briefly discuss the healthcare system of Malaysia. Right? You also need to learn about the healthcare system of Australia and what are the challenges which the healthcare systems of these two countries are facing. And also from a wider global perspective, what are the major changes faced by healthcare systems in the 21st century? Alright, meaning of the term national healthcare system. It refers to all the components that are involved in the organization, how it's organized, how it's set up, financing, how you raise funds and how you pay for healthcare of the people, and provision, how you supply services. Right? It's not only medical care, not only clinical care, not only GP care, hospital care, but also health-related social care, right? Nursing homes, facilities for disabled people, facilities for elderly people, and so on, right? Therefore, the national healthcare system includes things such as the Ministry of Health of Malaysia, Ministry of Health, and other components in Australia. Medical schools, right? Medical schools, private medical schools, as well as public medical schools. Insurance companies, private insurance companies. Sometimes it can be set up by the government, National Health Insurance Scheme, right? Drug companies, pharmaceutical companies, NGOs, non-governmental organizations, voluntary organizations, sometimes called PVOs, private voluntary organizations that provide social services. So this is what we mean by the national healthcare system. Okay, these are the main components of a national healthcare system. Most obvious, human resources. Right? When you ask people, ordinary people, lay people, person in the street, can you name some human resources used in healthcare? They talk about doctors, nurses, sometimes pharmacists, and a lot of the other human resources tend to be overlooked. Right? You also have allied health personnel, meaning people like occupational therapists, right? Physiotherapists, or in US they call them physical therapists. Right? You have diagnostic lab workers, healthcare administrators, the people who run the hospitals. Right? In Malaysia, a lot of the hospitals are run by people with clinical background, but not always so. Sunway Medical Center down the street. The CEO is Mr. Lau Bing Long, right? So he's not a clinician by training, so it's his other background, right? So it's possible to run a hospital even if you don't have a clinical background. And most of the hospitals in Malaysia, the public hospitals, the administrators are people whose first degrees are in clinical medicine. Facilities, example, clinics, hospitals, diagnostic labs, research centers, long-term care facilities, right? LTC, long-term care facilities such as nursing homes. Health information system. You must have a system to collect health data so you can see what's going on in the country, what are the most important diseases, right? The burden of disease, right? disability, death, right? Sickness, which are the most important diseases in a particular country, right? And so on, so that you can do proper health planning, so you can know where to focus on. Because from economics, resources are scarce, limited, so you must use them optimally, right, to get the most, better outcomes, right? Technology, health technology, vaccines, drugs, medical devices, surgical techniques, diagnostic equipment, right? MRIs, magnetic resonance imaging tools, and so on, right? Etc. Right? X-rays, equipment, etc. Financing system, how do you raise money for the healthcare system and pay the people who work in the healthcare system? One example is National Health Insurance, NHI. Some countries have NHI, National Health Insurance. In Britain, they have something called NHS, National Health Service, right? So the first movie I'm going to watch is a movie by an American documentary maker called Michael Moore, right? And the documentary is called Sicko, right? It focuses mainly on American healthcare system, but also describes other healthcare systems such as those of France, those of Britain, and so on, and Canada, right? Some of you here are from Canada. So, so when we watch the movie, after that, when you have discussion, I welcome your feedback about Canada, right? Okay, private insurance companies, right? The budget of the Ministry of Health, right? So in Malaysia, our Ministry of Health is allocated a fixed amount every year, and the Ministry of Health has to operate within that budget, right? Governance or health policy, what are the rules and regulations pertaining to the healthcare system, who are the regulators, etc. Right? MOH, Ministry of Health, regulators. Okay, objectives of national healthcare system. The first one is ensure provision of medical care that is timely, affordable, and of good quality. What do you mean by timely? Anybody? Timely healthcare? That means you don't have to wait too long. Right? You don't have to go to the hospital and wait 2 hours, 3 hours before the doctor sees you. Right? You don't have to travel too far. You don't have to travel 100 kilometers just to see a doctor, right? Or go to a hospital. So timely, right? So within a reasonable amount of time. Affordable. Affordable means you can afford to pay for it. You don't have to go bankrupt, right, to pay for your health care. Right? Half of all bankruptcies in the United States are related to medical bills. Medical bills, half, you know. Right? So actually even higher. I think that the figure will come out later in one of the slides. Right? So you don't have to go bankrupt to pay for your health care, especially hospital care. Right? For major illness or prolonged stay in the hospital. You don't have to borrow money from other people. You don't have to go into debt to pay for your health care. Good quality or reasonable quality. Right? The higher the quality of the healthcare, the more it may cost. So reasonable quality. Ensure medical care fees and drug prices are reasonable. So drug price should also be reasonable. Some drugs are very expensive, especially branded or proprietary drugs that cost a lot of money. Right? Ensure that social care is also provided. Example, long-term care for the elderly and the severely disabled. Right? The older you are, the more likely you have disabilities. And some people are young and disabled because they are born with disabilities. Some because they get into serious road traffic injuries and so on. Okay, protection of the health of the people through public health interventions. Example, control of disease outbreaks. Right, preventing disease from occurring in the first place. Example, compulsory vaccination against measles. Food inspection. In Malaysia, we have food inspectors. Right, you go to restaurants and so on. And sometimes you see the little plastic thing hanging on the wall. It says A, B, C. So if you're wondering what it is a food inspector grading the place. A means very satisfactory. C means poor, right? So try to avoid going to places where you have the C hanging on the wall. Try to go to the A's and B's. Right? It's food inspection. Okay, pollution control, air pollution, water pollution, solid waste pollution, noise pollution, right? E-waste pollution. What's e-waste pollution? All the old handphones thrown out, the computer equipment thrown out, and so on. So it's also another problem. E-waste pollution, right? A new thing in recent decades, right? Okay, this is the Malaysian healthcare system. It's a bit small, the slide. So after Ms. Chandra posted, you can look at it in detail. Right? So what it has is that in the Malaysian healthcare system, we have the federal government here, and then it's centralized, right, in Putrajaya, and then you have state and local governments and so on. Ministry of Health runs various facilities, but it's not only the Ministry of Health which provides clinical care, right? You also have armed forces. Malaysian armed forces has their own military hospitals. In the past, the Department of Aborigines, or the indigenous people of Malaysia, they ran hospitals and clinics for indigenous population. Nowadays, it's back to Ministry of Health, right? Because there were problems with quality and so on. So now the Ministry of Health are running and operating the hospitals for indigenous people. Ministry of Home Affairs, right? Home Affairs, in charge of the police and so on. Rehabilitation centers for addicts, drug addicts, right? Ministry of Education is also involved in health and the medical system, because it runs medical schools in some of the universities and also runs university hospital. The nearest one, University of Malaya Medical Center, just down the road. Okay, and then of course there's the public sector, the government sector. You also have the private sector. Private sector, you have private healthcare facilities, private hospitals, like Sunway Medical Center. You have private clinics. In Malaysia, a lot of the clinics, GPs, right, operated by private sector GPs. Some of the rubber plantations and oil palm plantations may have their own little clinics. Okay, sometimes factories, they may have occupational health doctors and so on. And then of course the other health professions, dentists, pharmacists, etc., etc. And not forgetting traditional and complementary medical practitioners, right? Okay, briefly, Malaysian healthcare system. These slides I obtained courtesy of my frequent collaborator, Dr. Simon Barraclaw of La Trobe University in Australia. Okay, so the public sector in Malaysia is strongly centralized with the Ministry of Health in control, headquarters in Putrajaya. Right, the government is the main provider of hospital care. So most of the people, when they seek hospital care in Malaysia, they go to government hospitals, not to private hospitals. The government provides public health measures and also primary health care, GP clinics, right? Klinik Kesihatan, Klinik Desa, meaning health clinics and community clinics in the rural areas, right? Okay. The private sector is a major provider of GP or general practitioner services, primary care, right? Private hospitals are growing in number, and most new hospitals are for profit. State governments, such as those of Johor State, right, also invest in private hospitals. Example, Kumpulan Perubatan Johor, the medical group of Johor, right, KPJ, owns a network of hospitals in Malaysia. The rise of private medical schools, right, more and more medical schools. In the past, there weren't any medical schools, but in the last few decades, you have an appearance of private medical schools in Malaysia, including Monash University in Malaysia, right? I think recently you may have read in the news about worries about surplus of doctors, right? Surplus of doctors. Okay, because now we have a lot of medical schools, including private ones, and we also have people who graduate from foreign medical schools coming back to Malaysia. I think all the Malaysian citizens here know that after you graduate, you have to do 2-year compulsory service with the Ministry of Health. Okay, so that's inherited from colonial days. In the past, it was 3 years. Now it's 2 years. Okay. You have a choice where you want to practice, right? Where you want to have your attachment in after you graduate. Okay, but some of the popular ones like Kuala Lumpur, Penang, very hard to get. Right? It's easier if you go to East Malaysia or go to the East Coast of Malaysia, etc. Okay, when you talk about doctor surplus, it's not such a straightforward thing. It's composition of doctors, like how many GPs you have. What's the percentage of specialists, and what's the distribution of the personnel, what's the specialty. In Malaysia, our population is gradually aging because of declining fertility rate, declining birth rate. Right? What we need are more doctors who specialize in treating the elderly, geriatricians. Right? We also need more psychiatrists. Right? Maybe our society getting more and more stressful, so it's another growth area. Psychiatry, not enough psychiatrists, not enough geriatricians. Okay, Geographical location, right? Are there shortage of doctors in certain areas of the country, rural areas, and too many doctors, quote unquote, in urban areas? So distributions are important. Okay, continue the Malaysian healthcare system. Care in public hospitals and clinics are provided at a nominal charge. So healthcare provided by the government, by the Ministry of Health, is heavily subsidized. Only 5% of total Ministry of Health expenditures are regained through so-called user fees. Right? 95% is financed by other means, commonly taxpayer ringgit. Right? So only 5% from user fees. There's no national health insurance system yet, but there are plans for one. Hospitals are concentrated in urban areas. In rural areas, there are the clinic kesihatan, health clinics, and clinic desa, community clinics. This can be staffed by non-doctors. Example, community nurses or public health nurses, and also by medical assistants. Medical assistants are people who provide basic care, but they are not medical doctors. They don't have a medical degree. Right? So again, this is another inheritance from our British colonial days. In East Malaysia, how many of you here from Sarawak and Sabah? Okay, these are big states. So in the interior, it may be hard to get to those places, those communities. So we have a flying doctor service, where you have helicopters and so on. Right? But the problem with flying doctor service is very expensive. Right? And those are communities which are very isolated. Maybe the doctor can only come infrequently. Right? So when there's a medical emergency, they have to find other means of getting the patient treated. Right? So Australia is a very big country. Australia is the size of continental United States, or the size of China. Right? So and so you have all these rural communities out in the outback. Right? So how to get to provide care to these people? So sometimes the doctor has to fly there in a light plane. Right? So the flying doctor service. Okay, this is the Australian healthcare system. Right? Slides courtesy of Dr. Helen Ackland. Okay, the health system, you have the primary care system, basic care, primary and community health services, example, GPs, AV, private, allied health, etc., hospitals, emergency department, right, inpatients, outpatients, and so on. Okay, then you have the more specialized ones, Australian Defence Force, Armed Forces, mental health, palliative care. What is palliative care? Anybody knows? It means people are already dying, terminal stages, right? You cannot cure them or anything like that. So they are actually basically dying, and you put them in palliative care, and it's basically giving them pain management, giving them drugs to control the pain, morphine and so on, right? In some states in US, they allow them to smoke marijuana, ganja, right? So they call medical marijuana, right? Etc. etc. Okay, so basically pain management and trying to make the patient as comfortable as possible before the patient passes away. Okay, and then of course public health services, preventive measures, health promotion, health education, and so on. Okay, Australian healthcare system, they have introduced health insurance, a public health insurance scheme called Medicare. This was introduced in 1984. It's compulsory, right? So you have to pay something called a Medicare levy, a tax, right? The aim is to make healthcare affordable, to increase provision of high quality healthcare, to increase access, right? So these three, when you talk about making it increasing access, price, reasonable quality, and accessibility. And later on, some slides will discuss what you mean by accessibility in one of the lectures later on. Is funded through general taxes, to GST, goods and services tax, and progressive Medicare levy. What do you mean by progressive? Anybody knows? Progressive? Okay, progressive means if you have higher income, you pay more, right? You pay a higher fee, so that's called progressive tax, right? Regressive means poor people pay more as a percentage of what they earn. Okay, so progressive versus regressive taxation. This is progressive. Okay, Australia also has introduced something called the Pharmaceutical Benefit Scheme, or PBS. Right? The aim of the PBS is to increase access to drugs, at the same time making sure that the safety is taken into consideration and quality of the drugs is taken into consideration. So what happens is that drugs which have been approved and placed on the PBS list are heavily subsidized by the government. Only approved drugs, right? So if you ask for drugs which are not on the list, then you have to pay full fare or whatever, right? Okay, so but drugs on the list are subsidized by the government. So patients only need to pay the co-payment fee. Co-payment fee means you have to pay a small fee, right, in order to be prescribed with the drug. This lowers the out-of-pocket price of drugs for patients. Out-of-pocket means you pay out of your own pocket, right? Out-of-pocket. Okay, special challenges in Australia. Indigenous Australians. The health situation of Australian Aboriginal population, the indigenous, is very, very bad. There's a lot of domestic violence, a lot of drug abuse, a lot of alcoholism, and so on. Okay, so the health indicators are poor compared to the rest of the Australian population. Australia is a very big country, it's vast, therefore you need a flying doctor service. But nowadays with telemedicine, you can do more. Telemedicine using Skype, using internet, etc., communicating, right? So a GP may be able to consult with another doctor or a specialist and so on to describe, to discuss a patient's case, right? So nowadays, X-rays can be taken and they can be transmitted electronically and interpreted by a radiologist at another site. Okay, so these are all called telemedicine. Nowadays, you have remote surgery also. The surgery can be another place and can operate on the patient here, right, in another location. Okay, and one of the most interesting things I came across was using drones in medical care, right? So there was an article yesterday from the BBC news website online, and they say that since the roads in Africa are so bad, sometimes you need to transport blood samples, collect the blood sample from the patient and needs to send it to the lab, right? In the past, they used to have motorcycles, but even motorcycle, you go on the country road, where there's no roads at all, or no roads at all, it can be a bone shaker, right? So what they do is, why not use a little drone and transport the sample to the diagnostic lab? Okay, so new technologies are making healthcare more efficient. Okay, extreme heat and bushfires. Australia is getting drier and drier, global warming, right? And one of the threats which Australians face, which we don't face in Malaysia, are bushfires. A few years ago, there was a serious bushfire in the state of Victoria in Australia, and our campus at Gippsland campus, right? And I think one or two people died. One or two of the Monash staff actually died. Right? The bushfires spread so quickly, everything was so dry. And also in Australia, the trees are eucalyptus trees. Right? In eucalyptus trees, they have some sort of oil, and they are more combustible, so burn easily. Right? And sometimes a strong wind, the fire may jump from one spot to the other. So bushfires are a danger in Australia, which we don't face in Malaysia. Right? Aging population, right? Obesity. Just as we mentioned, Australia is the second most obese nation after the USA, big portions. Healthcare in Australia is considered expensive and also poorly coordinated. Right? Okay, these are the major challenges faced by national healthcare systems everywhere. One is philosophical difference, right? And clashing economic interests leading to policy debates and policy differences. We'll talk about this later. Next slide. Cost control. In many countries, the governments are worried about rising healthcare costs for various reasons. One of which is due to adoption of new technology is expensive. Another one is aging populations, more and more elderly people. Quality issues, changing patterns of disease and emergence of new diseases, right? And other health challenges. Healthcare of socially excluded and marginalized groups, right? We'll later discuss what you mean by this. Effects of globalization. Okay, policy differences, different philosophies, right? Is healthcare the role of the private sector versus or the role of the public sector? Is healthcare a right, A right of citizenship, or should healthcare be based on the ability to pay? right? Certain countries like US, a lot of people think that healthcare should be based on the ability to pay. Other countries are right of citizenship. If you're a citizen or permanent resident, you should have a right to healthcare. But in the US, a lot of people don't think so, right? If you can afford to pay for healthcare, okay, you gain access, but you can't afford the healthcare, it's too bad, right? Individual, depends on individual circumstances. So is it a right, or is it of citizenship, or is it ability to pay, right? Should the state, meaning the government, regulate health-related behavior, or should they not interfere, and it's the right of the individual to live whatever lifestyle they like, right? So, for example, in Malaysia, we have a compulsory motorcycle helmet laws, right? So you ride a motorbike, you're supposed to wear a motorcycle helmet, right? But in Malaysia, a lot of people, they put on the helmet and they don't strap it properly, right? So which actually doesn't provide a lot of protection. You get hit by a car, you're going to be flying through the air, you land on your head or whatever, the helmet may also fly away from your head, you get serious head injury, right? So that's why in the past, the Ministry of Health has some public service announcements on TV asking people to please strap your motorcycle helmet. Okay, but in Malaysia, I think basically everybody, most people accept the fact that if you ride a motorbike, you should wear a helmet. But there's a large number or significant number of people in America who says it is not the duty of the government. The government has no right to tell me what to do. If I want to ride a motorcycle, I want to ride my Harley Davidson, big fat motorbike, right? Powerful motorbike without a helmet is my business. Right? It's not the concern of the government. Okay, and because of that, in some states in the US, there are no motorcycle helmet laws. You can just ride a motorbike. Right? There are 50 different states, 50 different sets of laws. Right? And just now we talked about the debate over gun control in US. So 70% of the people in America think that there should be some form of gun control, but 30% say no. If I want to buy guns and carry guns around, it's my business. It's not the business of the government to tell me what to do. Emphasis on individual rights, right, versus state regulation of behavior, right? So some people say when the government regulates behavior too much, it becomes a nanny state. Nanny nagging you all the time, do this, do that, not healthy for you, blah blah blah, and so on. So nanny, right? Okay. To what degree should the state regulate health-related behavior of individuals? Should the state pay for healthcare costs arising from such behavior? Okay, so these are philosophical debates, and for philosophical debates, there's no right answer. It depends on people's values and so on, right? Okay, so what should be the role of the private sector versus the public sector? Right? Private sector means private companies. Public sector means the government in healthcare financing and provision. Financing means raising money and spending money. Provision means supplying the services. Okay. So the basic question is: should the private sector supplement a dominant state system? Dominant state system, as in Britain, England, NHS, National Health Service. In Britain, they actually have 4 NHS. One is NHS Scotland, NHS England, NHS Wales, and NHS Northern Ireland, right? So should the dominant system be the state-run system and then you have a private sector, or should it be the other way around, the American system where the state healthcare system caters only for those who cannot afford private healthcare, right? So completely different system, US versus British system. Advocates of free market-oriented healthcare favor this system, right, the US system, while defenders of the welfare state favor the former. Welfare state. This is a government which is set up to provide social services for people, right? And they finance it by taxing the people. So yeah, you pay taxes, but then you get good quality services, right? So welfare states, example, would be Sweden, Norway, Finland, Denmark, etc. You pay high taxes, but the services you get are good quality, right? Okay, so the joke about the welfare state. Welfare state, when they first introduced the NHS, the National Health Service of England, in 1947-48, and the slogan was, the government will take care of you from the cradle to the grave. From the cradle, you're born put in the cradle. From the cradle to the grave. So some people try to be cheeky and they say, from womb to tomb. From your mother's womb to when you end up in the tomb. And another one, from sperm to worm. Okay? From the cradle to the grave, from womb to tomb, from sperm to worm. The welfare state. Okay, cost control. there's a perception that there's a problem with rising healthcare costs. Is this really so in Malaysia? The government claims that our healthcare costs are rising and rising, so we have to do something about it, right? Okay, these are some statistics. The allocated budget of the Ministry of Health in Malaysia, 1990 to 2009, right? So what do you see here? What's the trend? It's going up, right? The curve is going up. Why is there a dip here? Okay, why is there a dip here? Recession. Actually, the recession is in the late 1990s. I don't even know. I have to find out. Okay, so there's a dip there, right? So these are in nominal RM, nominal ringgit. That means not adjusted for inflation. But even after you adjust for inflation, the trend is still there, upward. Right? So when you look at it superficially, it says that our costs are rising and getting more expensive. But when you analyze it carefully, not necessarily the case. Okay, I argue that the Ministry of Health budget is stable as a percentage of the national budget. These slides are from lectures I give to Ministry of Health people. So every year they invite me to give lectures on healthcare, financing, health economics. Right? So I've been doing this for the last few years. And so I show them all these kind of slides, right? So these are slides which I also show to you. Okay? So my argument is that the Ministry of Health budget is stable as a percentage of national budget. It means each year our budget is getting bigger, and the percentage actually stays quite stable, right? So stays quite stable, right? Okay, if you look at it from a comparative perspective, total spending on health for nations with comparable gross national income GNI per capita, that means divide by the size of the population, and you use something which is comparable called purchasing power parity international dollars, PPP, purchasing power parity. You can see this, right? These are countries which are equivalent in terms of gross national income per capita, right? That means at the same economic level, and then you look at how much they spend, adjusting for purchasing power parity. So what do you see here? Total health expenditure as percentage of gross domestic product in a country called Chile, 8% of GDP. Turkey, 6.7%. Argentina, 8.1%. Mexico, 6.3%. Malaysia, how much? 4.4%. Good. Stingy. Right? So we only spend 4.4% of our GDP on health, right? And yet we claim, or certain people claim, that we are spending too much, right? Okay, public spending on health for nations with comparable gross national income per capita, again in PPP. Okay, now this is government health expenditure as percentage of all government general expenditure. Right? So again, Chile, 16.3 of all general government expenditure is 16.3% spent on health. Turkey, 12.8%. Argentina, 14.7%. Mexico, 12.1%. And we spend 9.2%. Right? 9.2%. Okay. So here, this shows that when you look at statistics, and be careful. Don't just take it at face value. You must analyze it carefully. So when superficially you look at the graph, the spending is going up and seems to be getting out of control. But when you look at it from other dimension, other angle, and compare to other countries, it's not necessarily the case. Right? Quality issues. Healthcare needs to be made available, affordable, as well as adequate quality. Substandard healthcare can harm or even kill patients. There's a famous study published by the Institute of Medicine of the United States in 1999, which claimed that many patients have been harmed or killed by medical intervention itself, including drugs prescribed to them. Right? So medical intervention can actually harm people. Right? If a drug is prescribed incorrectly, wrong dose, etc., right? Or polypharmacy, elderly people have many health problems at the same time, and if there's no coordination, then one doctor prescribes one drug, so it may have interact in a dangerous manner. Okay, so medical intervention itself can actually harm patients. Okay, changing patterns of disease, increase in chronic diseases. There's a difference between infectious diseases and chronic disease. The infectious disease spread one person to the other. Chronic disease is like a disease which persists throughout your life. Right? Sometimes you can manage it, sometimes it get out of control. Right? So examples of chronic diseases are diabetes, the various forms of arthritis, cardiovascular disease and so on. So you have to live with it and you have to manage it. It can't be cured, right? So you manage it. Okay. Appearance of new infectious diseases such as HIV/AIDS. Later in the semester, you watch a movie called "And the Band Played On." It's a history of HIV/AIDS, right? How it was detected in the beginning until a few years later, right? HIV/AIDS is comorbid with TB. People are infected with HIV are more likely to have TB. Okay. New health-related problems. Obesity. Obesity is getting worse in many countries, right? People are too wealthy, too much junk food, right? Spread of American junk foods and so on. McDonald's, KFC, what else? All the other ones, right? So when I show you the documentary of Super Size Me, so this guy ate McDonald's for breakfast, lunch, dinner for 1 month, right? 1 whole month, and then he has all his blood chemistry analyzed and so on. Okay, so it's a dangerous experiment. Okay, it's not very scientific because it's only one person, right? Proper scientific study, you must have adequate sample size, you must have experimental group and a control group. Okay, but he did as some sort of stunt, also very interesting, right? Okay, cancer related to environmental pollution, occupational exposure, right? So environmental pollution can increase the risk of cancer. Occupational exposure, if you work in a workplace where you're exposed to all sorts of things, also the chemicals and so on, it increases the risk, right, of certain kinds of cancers, right? Occupational injuries, injured on the job, transport-related injuries related to the increase in the number of motor vehicles, the state of the roads, how dangerously people drive and so on, right? I've never been to India, but I've heard some interesting stories from India. So if you drive in India, there are potholes everywhere, right? There are cows everywhere. Cows are considered sacred animals. The cows defecate everywhere, urinate everywhere, and so on. And population is very big, so it's very, very crowded, right? So last time we had one of my colleagues, a former colleague, is no longer here. He said he was taking a train in India. He had a shock because he was sitting on the seat and somebody sat in his lap. And apparently that's what people do, no? They just sit on your lap because it's so crowded. And sometimes you have people sitting on top of the train itself, on the carriage itself. It's dangerous, so you can fall off, right? And when you go through a tunnel, you're talking to your friend after the tunnel will hit the top of your head, right? So too crowded, too many people, right? So what to do? Very high rate of population growth, very big population. Right? China is another place. Very crowded, right? Don't know how many of you have been to China. It's quite uncomfortable, no? When you go into a subway, the Beijing subway, right? In Cantonese, we have a saying which goes "Yan San, Yan Hoi." People mountain, people sea, right? That means there's so many people there. Everywhere it's like a mountain, it's like a sea. So very uncomfortable. Hong Kong too. Hong Kong very crowded, right? Extremely crowded, and people live in very small flats, very small, right? Japan is another country which is crowded. Tokyo is very crowded. So during peak hours, they employ push people into the carriage, right? But Japanese people are very polite. The society is very polite. Everybody is very polite, very well organized, and so on. So still bearable, I suppose. Right? So I did some research in Japan for 3 months, and I lived in a little town outside of Osaka, right? So that was okay. So there was a place called Sanda, right? Sanda, so it was nice. So it was people live in Sanda and they take the train into Osaka to work, right? But the city itself very crowded, too many people, right? So I don't understand, but young people seem to like cities. The same thing in Malaysia. A lot of people from small town and so on, they move into Kuala Lumpur, they move into Penang. Although the cost of living is more, they enjoy it, right? But for people like me, I prefer a small town. When I retire, I want to go back to a small town. I don't like Kuala Lumpur very much. I've seen a lot of the world, and I don't like big cities generally. Too expensive, too many people, not as safe as small town. But it's a personal preference, right? Okay. How will climate change affect the patterns of disease? Right? Nowadays we have global warming or anthropogenic climate change, human-induced climate change. So the evidence is getting stronger and stronger that our lifestyle is affecting the climate of the world. Australia is getting drier and drier, more and more droughts, right? Stronger and stronger hurricanes in the Caribbean, right? Stronger tornadoes and so on, Okay, as the ocean warms, surface temperature gets warmer, then you have stronger hurricanes and etc. Okay, there are some people who claim that there's no such thing as global warming, but the vast majority of scientists, the consensus is that there is something is going on, right? Something not really pleasant. Okay. All right. Healthcare or socially excluded and marginalized groups. What do you mean by socially excluded groups? People who do not participate fully in the activities of the society which they live in. Example, people who are long-term unemployed, right? People who are addicted to drugs and so on. Socially excluded groups, right? Marginalized groups, people who live on the margins of society, right? Extremely poor people and so on. Example, ethnic minorities such as the Roma, the so-called gypsies in Europe, Orang Asli in Malaysia, indigenous Australians. These are marginalized groups. I mentioned long-term unemployed, drug addicts, refugees, right? Do you all know there are refugees? There are lots of refugees in Malaysia. You know that, right? So we have refugees from Myanmar or Burma, and last time we used to have refugees from Indonesia, from Aceh, northern Sumatra, right? So some of them invite them to come and talk to you, and the NGO staff will help them, will come also, right? And a few years ago, we actually had a refugee from Burma who has a medical degree, medical doctor, right? Okay. Illegal immigrants, also called undocumented aliens, people who are in this country illegally, right? They live on the margins of society, right? These groups tend to be medically underserved. This means that they have a lot of health needs which are not adequately met by the existing healthcare system. The medically underserved, right? Okay, globalization and health. Globalization is a phenomenon of greater economic and social integration across different regions of the world. That's what I mean by globalization, right? One example of globalization is cross-border spread of disease. Example, the SARS epidemic, severe acute respiratory syndrome, first detected in southern China, spread to Hong Kong, spread to Singapore, spread to Canada, right? So the healthcare system needs to contain imported diseases quickly, right? So in Malaysia in the past, we had brought under control filariasis. You know what's filariasis? Elephantiasis, where you have the worm going around your body and then the legs swell and so on, right? And for the most unfortunate, even the testicles also swell, right? So I think in the past we didn't have such a problem, but now we have immigrants coming from Indonesia, undocumented aliens. So now we have filariasis cases here, right? And other imported diseases, right? Emigration of health personnel such as doctors and nurses from poorer countries to richer countries, example, is a severe problem for the Philippines, right? Philippines, the economy is no good, the standard of living is poor, doctors are poorly paid, so a lot of the doctors who graduate, a lot of the nurses who graduate actually migrate overseas to work. There's a lot of Filipino doctors and nurses who work in Britain, excuse me, work in the US and so on. And what's interesting is there are actually some Filipino doctors, you know, who migrate overseas to work as nurses. Filipino doctors who migrate overseas to work as nurses because when they're overseas, they actually can earn more, right? Comparatively speaking. Okay. Many doctors in Singapore are actually from Malaysia, right? Malaysia, we have historical ties, but a lot of our doctors, a significant number actually migrate and work in Singapore, right? Singapore government recognizes 2 medical schools in Malaysia. One is a University of Malaya, and the other one I think is a University Kebangsaan Malaysia, UKM and UM, right? The rest they don't recognize. Okay. Malaysia itself, we import doctors from Myanmar, from Burma, from Pakistan, from India, and so on. So doctors move from poorer countries to richer countries to even richer countries. So medical migration. So this is a challenge, right? Okay, we import expensive medical technology from Western countries. Ministry of Health regulates importation of technology into government hospitals, but in the private sector, it's largely unregulated, right? We also import ideologies such as privatization of healthcare from the UK. Privatization means things which are done by the government in the past are now passed on to the private sector. Private sector do it for profit. Last time it was non-profit, now it's for profit. So there's privatization, right? Global climate change and its health effects. Will there be climate change refugees? It's already occurring. We already have climate change refugees. In the South Pacific, there's an island called Tuvalu, right? The sea level is rising, so salt water is entering into the island during storms and so on, and affecting the agricultural land. So people actually have to move out, right? And if you, I don't know whether you all read the news in a few years in the past, the president of Maldives Island was so worried about global warming. Maldives is a few islands in the Indian Ocean, which are just a few meters higher than the sea level, right? So what he did was he got his entire cabinet to have a cabinet meeting underwater, wearing scuba equipment. Very dramatic, very attracted attention overseas. He's saying that all you rich countries, your lifestyle is actually releasing a lot of greenhouse gases into the atmosphere, and there's the poor countries which are going to pay the price, right? So in the coming decades, we'll have more and more climate change refugees. The country of Bangladesh, very low lying, right? So increasingly being threatened by rising sea levels, SLR, sea level rise, right? Okay, violent storms, extreme temperatures, right? In the last 2 weeks, we have had very high temperature in Malaysia, right? Extreme temperature. We have had extreme temperature in Europe where people died, in France and so on, right? Elderly people, young children, etc. Okay, so Tuvalu, right? Okay, here's a reading on global warming, human-induced, adverse climate change, or anthropogenic climate change. So there's a reading there, you can read this. Okay, here. Why are so many doctors unhappy? Remember, I wanted to keep you in suspense. So why are so many doctors unhappy in the US? 52% unhappy. First reason, reduction in clinical autonomy and increase in accountability to external parties. That means how they practice medicine is being subjected to scrutiny by other people, by insurance companies, etc., etc. Right? So loss of clinical autonomy. Cost control. Americans are very worried about the price. Cost control and quality assurance have resulted in the growing use of guidelines, protocols. Protocol means you have to, if you have a normal case of disease, how should you treat the patient, etc., all laid out, right? Protocols, audit, regulation, inspection that many doctors perceive as eroding their control over their professional lives. Employers have also increased emphasis on numerical targets. So you work for the employer, you must see how many patients an hour, etc. You must generate how much revenue from the patients and so on. So loss of autonomy, right? Emphasis on efficiency. This is due to how the healthcare system itself is organized. Another one is change in patient behavior, changes in relationship with patients, decline in deference. In the past, when the doctor say this, the patient say yes, yes doctor, yes doctor, yes doctor. Nowadays, they're not happy and say, I will sue you. So, decline in deference. Patients demand more services. They want, and also because now they have more access to information on the internet, right? And the research finding shows that people tend to believe what they read on the internet, just because it's the electronic form, right? Sometimes all sorts of nonsensical stuff, they read it and they believe. And there are some patients who read about the latest medical drugs, latest medical procedure, go to see the doctor and say, doctor, I want this drug, right? And so on. Okay, so patients have become more demanding, right? Unrealistic expectations by some patients about the power of medicine to cure, right? Remember, there are some diseases where you cannot be cured, like chronic diseases that can only be managed. So this is due to social change. Okay, this is another good documentary called Sick Around the World. We look at healthcare systems of different countries. This one I remember I mentioned earlier about the medical school in Cuba, Latin American School of Medicine. This is a good documentary. It's a bit long. This documentary follows 6 students in Harvard Medical School, one of the most prestigious leading medical schools in America, and they follow them through the 4 years of medical education. Over there is 4 years, not 5 years, right? 4 years of medical education, and eventually their career as doctors, right? So I highly recommend this documentary. You all watch it, right? Some of you may be inspired by it. Some of you may be a little disappointed or a little worried, but that's the territory. This is your future life as doctors. Okay, so I recommend these documentaries. Okay, thank you. Any questions? Okay, please give me back the attendance sheet. Right? Okay, thank you. So I will see you all next week.